In Chapter 2, we will be going over organizing and administering an athletic healthcare program. In this chapter, we will be covering rules of operation for an athletic healthcare program. These include providing coverage for events and practices, athletic training room policies, keeping facilities clean and maintaining good personal hygiene, and we will go over the emergency action plan. As far as providing coverage for a given sport, what we mean there is the athletic trainer will be available for any injuries or illnesses that occur during sports participation. So that's what coverage means. Coverage depends on staffing and team needs. So if there's only one athletic trainer at a high school, they can't possibly be at every single sport at the same time. So if there's only one staff member, you have to prioritize by injury risk, basically. For a school that has, 12 athletic trainers, you should be able to get coverage for every practice and every game for every team. So if there's a setting where it's difficult for the athletic trainer to attend a practice for a specific team that is maybe lower risk, then it might be okay to have a CPR certified coach or teammate available at that practice. So say, for instance, when I worked at UCSD with the sports clubs teams, I attended every rugby practice and game outside of conditioning, but we never covered any dance sport events. So dance sports like ballroom dance. Having a CPR certified teammate there was appropriate for their needs. If people did get hurt in dance sport, it wasn't necessarily at an event, and usually they just came to the athletic training room to see us for that, and it was fine. It was usually more overuse type of injuries as opposed to a concussion or something like that. In a fitness setting, all staff members should be CPR and first aid certified, including members at the front desk, in my opinion, because if somebody gets hurt or ill and they're able to be moved, they're more likely to go to the front desk to seek help, and so the person in the front should know what to do. So as far as deciding whether or not a team will receive coverage for events or practices, it's going to make a difference whether or not it's a contact versus a non-contact sport. There should always be athletic trainers available for a contact sport, such as rugby, lacrosse, football, things of that nature, especially if there's going to be contact during practice. When I worked at UCSD, we actually stopped covering ice hockey practice because they were mostly skating and practicing drills. They didn't really do contact, and we told them to let us know ahead of time if they planned to scrimmage, and we would come and cover practice. As far as non-contact sports, that would be things like track and field or tennis or something like that. It doesn't mean people don't get injured in those sports. It just means that usually the injuries are not as severe, and it isn't as important as for a medical professional to be there immediately when they happen. They might be able to come over from a different practice to come treat that person. Another concept we talk about with coverage is central location versus rotating coverage. In an athletic training setting, if I had multiple teams practicing at the same time that had a similar risk level, and they were either non-contact or low-contact sports, I would oftentimes stay in the athletic training room so that people knew where to come and find me. Or during fall, I was always at football practice, but then soccer practice was nearby, tennis knew where I was, so it wasn't as big of an issue for those sports. Other times I would do rotating coverage. So say, for instance, if we had a tennis match, a baseball game, and a softball game all going on at the same time, I would rotate between those sports because they all had similar risk levels. And I would rotate between them, and then the coaches would have my cell phone number if something happened at their particular venue and they wanted me to come over right away. but I always made sure people knew where I was planning on going. In a fitness center, there should be at least one staff member centrally located in a larger facility. Now, if you're working one-on-one with clients, obviously that's not necessary. The person knows where you are because you're with them the whole time. But in a larger facility, you should have somebody who's at the front desk constantly. So even if the front desk person has to go on lunch or something like that, you just have somebody come up and cover the front desk for them for both customer service needs and any type of medical issues that might come up. As far as athletic trainer versus athletic trainer and doctor, it's not uncommon for doctors to cover football games and higher contact sports like soccer, sometimes at universities. For rugby, at UCSD, we used to use a physician, but at USD, where I currently work, we don't have a team physician available to us for games. So we use the Student Health Center for a primary supervising physician, so it's a little different of a situation. So for rugby and football, you could definitely make the case for having an athletic trainer and a doctor. They're very high-risk sports with high-risk injuries. Now we are going to go over common policies in an athletic training room. Policies are guidelines or rules of behavior which help keep order and cleanliness in a medical facility. Common athletic training rules would include no cleats in the athletic training room. They mark up floors and can cause damage to our tables. Also, no shoes on tables for the same reason. We don't want the tables to be damaged by shoes. Although in physical therapy clinics, people will often be allowed to leave their shoes on as it can be difficult for them to remove them. Athletes should shower prior to receiving treatment. Oftentimes athletes are coming in from sport and they can be covered in grass or mud or just super sweaty, and they're more likely to transmit germs, things that we don't want to have spread around if they've been sweating and working out prior to coming in without showering. Now, we're not going to make somebody who just had a bad ankle sprain shower before coming into the athletic training room. That's not very nice. We'll just clean up extra well when they're done. No food or drinks. Some of the machines in the athletic training rooms can cost $3,000, $4,000, $5,000, and we've had people actually spill drinks on a machine before and cause some damage when I worked at UCSD. So that's the main reason why we didn't allow drinks. And we also used to get mice every spring in the athletic training room, so that was part of why we didn't allow food. So for some people, if they had to eat, but maybe they were on their lunch break from classes, we would just ask them to eat outside. Common fitness center rules would be things like bringing your own towel to wipe off your own sweat, cleaning off machines after each use, again, to make sure we're not spreading any germs to other people, and because it's kind of gross to sit down in somebody's wet sweat, and no gum or food. Primarily because we just don't want people choking, especially on gum. As far as the importance of having clean facilities and good hygiene, this is important because an athletic training room is technically a medical facility, so we want to treat it as such. So as far as athletic training room and fitness center cleaning, tables and or machines should be cleaned between uses. Carpet should be vacuumed daily, and if there's a cold tub or a whirlpool, that should be drained and cleaned at least daily. In physical therapy clinics, if they still use whirlpools, which isn't very common, they actually are usually drained and cleaned between patients. As far as good hygiene for athletes and clients, we want to make sure people are not sharing personal equipment, clothing, or towels. That's a really good way to spread diseases, especially skin diseases. If people are sharing water bottles, we want to make sure they're not putting their mouths on the water bottles. It's one of my biggest pet peeves when people use a water bottle as a cup, or if they drink out of it like a baby bottle. It's a really good way to spread diseases like mono and meningitis. So, and just the regular cold or flu as well. So we really want to make sure people are not doing that. We want people to wash their hands often. That is the number one way to prevent illnesses being spread. And also like we talked about earlier, showering after a workout to make sure we're not spreading skin diseases or germs that are living on skin. Another important administrative task when it comes to athletic healthcare programs and actually fitness centers and other facilities like that is having an emergency action plan in place. This is a preset plan, a typed out plan that gives specific directions and is in place to help emergencies run smoothly. As human beings, when an emergency happens, a lot of times our cortisol levels spike, our adrenaline levels spike, and we become kind of stupider than we are normally. So we really need very clear directions on what to do in case of an emergency, delineated in a place where it is easily located to help people in an emergency. So the first thing the emergency action plan is going to do is it's going to delineate roles, so basically assign jobs to people, and give clear instructions for what to do in case of an emergency. We want to make sure that people who are reading the emergency action plan will know where to find an athletic trainer or a CPR certified employee and when they are available. So if we are saying that the athletic trainer can be found in the athletic training room, we want to give the hours that they're available. Say, for instance, we want to give the location of the nearest AED, first aid kit, and landline telephone. Sometimes in emergencies, such as when we've had fires in the past here in San Diego, some people are calling so much on their cell phones that they actually will clog up the line and you won't be able to call out. So it's important to know where a landline phone is. Another reason why it's important to know where a landline telephone is because when you call 911 on your cell phone, it could, if you're close to the freeway, actually go to the highway patrol. That's actually not very helpful if you're calling from a facility versus from the road. The other thing is that if multiple people are calling from their cell phones, you could end up with having multiple ambulances sent to one emergency, and that's a really big waste of resources. So it's always best to call 911 from a landline phone if possible. Especially here on campus, we actually they'd prefer to call from a landline number, and we would call, instead of 911, the campus dispatch number. We want to make sure and provide a phone number to contact EMS, and again, it's not always 911. So here on Miramar College's campus, we would call dispatch instead of 911. In our classroom, we have a button, a red button by the door that you can push, and that also goes straight to dispatch. And we could do that in our classroom. We also want to make a note of what to say when we call EMS in that emergency action plan. Continuing on with the emergency action plan, we want to give the venue address. So it would be, in our classroom, it would be Miramar College's address, and then also the building letter and room number. We also want to give venue directions. So that will be different for each building on campus. Say, for instance, at Miramar College, the directions from the parking lot would be different. We might direct EMS to a different parking lot, even if we were in a different part of the campus. So if we were in the M building versus in the J building, it may make we're going to want to have EMS park in a different spot. We're going to want to give directions on where to meet EMS. So we'll have a staff member assigned to meet the ambulance as it arrives and help direct them to the scene, because they probably won't know exactly where they're going. So it's easier to have somebody walk out and direct EMS back to the scene of where the person has been ill or injured. For an athletic training room or for fitness center, we want to have the phone numbers for the sports medicine staff or the venue supervisors. So you want a phone number, and also location is good for say for instance, the fitness center manager. And we do, again, need an EAP for each venue on campus. So the EAP for the M building is going to be very different than the EAP from the J building, because the access points are particularly very different. Where the AEDs are capped is very different as well. So this is an example of a very, very general EAP from your textbook. So these are the types of things that you would have in your EAP that you will be writing for your first assignment. And we're going to go over that more in class. So I don't expect you to be able to complete that assignment just based off of this information. But this is just an example. So we want to make sure we have actual phone numbers, actual address. This is definitely not an exhaustive list of the role of the first responders because we'll have a lot more in that area. We'll have a lot more specific directions on what to say when we call 911 because it basically doesn't say anything. You know, the venue directions are somewhat helpful, but it's not really super helpful. So this one, again, is just kind of showing you kind of how you could organize it, but it's definitely very, very general. If you were to turn this in, it would probably get a C or a D as far as grades go. So this is not the best example ever, but it's a starting point as far as how to organize things a bit. Okay, moving on from emergency action plans, we're going to talk a bit about record keeping. So we have just some different areas we look at with record keeping, and we'll get more in depth in later slides. We have pre-participation physical exams, and we're also going to talk about release of medical records, injury reports, treatment logs, and injury evaluations and progress notes. When it comes to pre-participation physical exams, this is an exam that is done possibly in a group or possibly by an individual's physician that is used to assess risk. So basically, we're looking for any pre-existing conditions that could make it more likely for an individual to become ill or injured while participating in a sport. So this can be done individually, like somebody could go to their personal doctor and have them fill out the form and they would go through the different parts of the physical, or we can do it in stations. So usually if somebody is coming through the pre-participation physicals at a university, they're going to be doing the stations. So step one, we would always have them complete a medical history form. And again, this is independent of whether or not they're seeing the regular physician versus going through stations. But this is asking things like, has anybody in your family died suddenly before the age of 55? We're looking at risk for heart issues there. Are you missing a paired organ? Do you have you ever been short of breath or passed out with exercise? Also looking for heart issues there. Have you had a recent surgery? Things like that. Then that medical history form is going to help direct the physical exam. So the doctors are, so an athletic training student, an athletic trainer or a nurse can check the height, weight, blood pressure, pulse, and vision. From the height and weight, we'll calculate the body composition, which you guys are going to do in class. You will also learn how to do blood pressure and pulse and vision if you've never done it before. And then when the athlete sees the doctor is going to do what they call looking at their systems or evaluating their systems. So, you know, skin, teeth, ears, nose and throat, heart and lung function. They're going to check their abdomen for any tender spots or things like that. They're going to check their head and also talk to them about any concussion history. They may check external genitalia on males if they have any sort of report of things being different than normal. Usually in the mass physicals, the doctors didn't check that when we worked at UCSD unless the athlete had complained of a history of hernia or any kinds of symptoms that could be associated with hernia. For younger kids, maybe junior high or high school, they would do a maturity assessment as well. So that's step 2 for physical exam. Step 3, they would do an orthopedic screening. That could be done by a doctor or an athletic trainer. So basically checking to make sure all the joints are working properly and the athlete is able to move through normal, comfortable ranges of motion. And if they've had any past surgeries, just checking to make sure that particular surgery has healed. Step 4 is always sport clearance or disqualification. So if somebody is not able to play the sport, they will be disqualified. And we'll talk more about that later. But sport clearance means the person can just go back to, or go out and play with the rest of the team with no restrictions. So as previously mentioned with the PPE, the medical history form is always done first. And again, we're using this to direct the physical exam. We're going to ask them about previous or ongoing medical or orthopedic problems, previous surgeries, medications, allergies, family history of heart problems or sudden death under the age of 50 or 55 is when we're most concerned about that. Other things that we will ask about in a medical history form include if the person has seizure disorder. For contact sports, that could be more of an issue, or if somebody maybe is playing water polo or swimming and they're having uncontrolled seizures, that would be a concern as well, since they could technically drown. But if somebody has seizure disorder that is well controlled, that wouldn't necessarily preclude them from playing. We want to know if somebody's had a concussion in the past or a suspected concussion. There's no magic number of concussions that will keep somebody from being able to play a sport, but I know when I worked at UCSD that the physicians would become more concerned if an athlete had 3 or more concussions within a short time span. So it takes a while for the brain to heal after concussion. So if they're having concussions more often than every 2 years, or if they've had multiple concussions, then we would maybe ask them to do some follow-up testing to make sure they were okay. Loss of a paired organ might be another thing that we would be concerned about. If somebody was an awesome tennis player and they had lost an eye, no big deal. Same thing if they lost a kidney, no big deal. If somebody lost a kidney or a testicle or something like that and they want to play rugby, that's more of a concern. Because if they damaged their other kidney or their other testicle, that could cause lifelong damage that would cause them to have to go through many treatments or medications to have to treat later on in life, even though that person would function totally normally without that paired organ if they had never played rugby and damaged the other one. So we want to be very careful with some people with loss of a paired organ. We want to ask about psychological issues. And this is more just to make sure that we have a complete history on this person in case they all of a sudden start acting really odd. Maybe somebody's showing us signs of disordered eating patterns. It'd be helpful if we knew ahead of time that they tend to have those issues, and it would maybe help us to be able to head off some of the problems they could have from that and possibly get them in help sooner. Or if somebody is bipolar, say for instance, excuse me. So if someone had, say for instance, bipolar disorder, we would definitely want to make sure we knew that ahead of time to make sure that we were following up with them and that they're continuing to take their medication to be able to be a functioning member of society and of the team that they're on. Another thing we'd be interested in knowing about is for women, their menstrual history. Menstrual history is or can be an indicator of general health. So if somebody only has a period once a year, that's not really normal. Our hormonal systems, if they're functioning normally, would make us have a period more often than that, like usually around every 28 to 30 days. That's a little bit more normal. For an individual, that could be how they normally are, and maybe they've seen a doctor about it. But if they haven't, then we would probably want them to follow up with the team physician to make sure that there's nothing that's being missed as far as them being at their best health. Another thing, if somebody's only having a period once a year, that could indicate is maybe their BMI or their weight is too low, and they're body is not able to produce hormones in a way that is necessary to keep their body functioning normally. And that would be very helpful information as well, so we can counsel them as far as making sure that they're keeping their body weight up and making sure their hormones are functioning. Previous injuries or illnesses may require documentation to be sent to an MD or an athletic trainer, and they may or may not make it so the person becomes disqualified. It just depends on the situation. So now on to physical exam for PPEs. We usually check height and weight pretty early on, and then we use those to calculate BMI, or body mass index. And BMI is used to identify under or overweight athletes. Unfortunately, it's not always very accurate for muscular individuals like athletes, so that's unfortunate. Somebody could be very muscular and be technically obese. I had a student in class one year who probably had, I would guess, a 28-inch waist, but because he lifted so much and had such a big muscle mass, he was actually considered overweight, almost bordering on an obese scale. It was very interesting. And he looked small, but it was just because his weight was very heavy because of his muscle mass. The main thing we look at is BMI for individuals under 18.5 or over 25 may be at risk for health problems. So if somebody wasn't extremely muscular and their BMI is over 25, then we might look at things like possible issues with cholesterol, heart conditions, diabetes, things like that. Having said that, if my husband at a healthy weight hovers just above 25, for him he tends towards being more muscular, and so it's hard for him to get his BMI below 25 without looking sick. I've had some students in class who were under 18.5 and looked fairly normal for their ethnicity and gender, and that can be normal because people from certain ethnic backgrounds, their bones are actually lighter, so their overall weight, or I should say lighter than somebody from a different ethnic background. So their overall weight may actually seem less or be less than it looks from the outside. The BMI is helpful, but it is not the end-all and be-all as far as health in terms of body composition. Also, side note, BMI was actually developed by insurance companies to give them a very easy way of not having to actually see somebody or touch somebody, and give them a way to identify people who might be at a higher risk for getting illnesses. Another important component of the physical exam is body composition. So BMI, sometimes we group it in with body composition, but it technically doesn't tell you what the body's composed of. It just tells you the comparison of the height to weight. So true body composition would be testing for body fat percentage. So you can do this using skin folds and a caliper like this top picture here with the green caliper, or you can use a handheld device that would be called a bioelectric impedance device, and that passes a small electrical current through the body. The skin folds are going to be more accurate if the tester is skilled, if they've had a lot of practice, especially with larger individuals or individuals who have a higher body fat percentage. It can be very difficult to get a really good skin fold and measure it in the right spot. So the more practice the person has had, the better they are going to be at this. For the skin folds, we want to use at least 4 sites. Some equations use many more. And with the calipers, those are measuring the skin fold in millimeters. So it's not something that somebody can estimate with their fingers. You really need the measuring device to be able to estimate these skin folds. As far as a handheld device, the bioelectric impedance device, those are not super accurate. The problem is that they are very highly dependent on the individual's hydration status. because if somebody's dehydrated, the electric current going through the body is going to be very different than if they are properly hydrated. So if somebody wants to really get an accurate reading on one of those, they need to make sure they're properly hydrated prior to using one. So that's body composition. Those are our easy ways to test that. There are other ways as well that we will discuss in a later lecture. And body composition isn't always checked in every PPE, but it's sometimes used as a helpful tool. Blood pressure is always checked in a physical exam. When we're checking somebody's blood pressure, we need a quiet place to test to make sure we're hearing the sounds from the blood vessels accurately. The other thing to think about with blood pressure is, say for instance, if we're looking at this normal blood pressure here on the slide, we're looking at the numbers being 120/80. That's how we read that. The 120 on top is called the systolic pressure. That is the pressure when the heart contracts or squeezes. And we're measuring the pressure on the blood vessels when that happens. And then the diastolic pressure is the 80, so it's the bottom number. And the diastolic is the pressure on the blood vessels when the heart is in a relaxed state. So there's always some amount of pressure on those blood vessels. It's just not as high when the heart is relaxed. So when we're looking at somebody's blood pressure and recording that, the top number will always be a bigger number than the bottom number. It is impossible for the diastolic or the bottom number to be bigger than the systolic pressure. That's not possible. They could be close, but it's not possible for the bottom number to be bigger than the top number. As far as somebody having high blood pressure that we would want to follow up on, we're looking at anything that's above 135/85. That doesn't mean they're going to be disqualified. It just means we want to watch them and make sure they're not getting worse. As far as lower blood pressures, usually that's considered a sign of health. Some people can be too low and it can cause symptoms like dizziness or nausea or lightheadedness, things like that. So there is such a thing as being too low when it comes to having symptoms from that. But generally speaking, having lower blood pressure is not considered a concern. So the next part of the physical exam that we will do is we will take the pulse. That is usually best taken at the radial pulse on the wrist versus at the carotid pulse on the neck. Both of them are considered accurate ways to check pulse, but it can be slightly more challenging to get an accurate pulse with the carotid pulse on the neck because sometimes you can accidentally read breathing as the heartbeat in the neck. So I like to personally use the radial pulse at the wrists more for this. A normal range for pulse would be 60 to 90 beats per minute. Bradycardia or slow heart rate would be under 60 beats per minute. This is okay for highly trained individuals. I've seen pulses as low as 30 beats per minute with one of my friends who was training to be a Navy SEAL. He was extremely highly trained, had been a distance runner previous to joining the SEALs, and when he became a Navy SEAL, their training even further decreased his heart rate purposefully. They do that on purpose in their SEAL training. So he was very, very highly trained at that point, and his heart rate was around 30 beats per minute. That's not normal, though. Most people wouldn't feel very well if they were that bradycardic. As far as being tachycardic or having too fast of a heart rate, that's going to be a heart rate that's over 90 beats per minute. That's considered slightly stressful on the heart and blood vessels. Same thing as far as having higher blood pressure, that is also stressful for the heart and blood vessels. But we may or may not follow up on that. A lot of times that's an indication of some kind of stress, either personal stress just within their life. Maybe they hate going to the doctor, or they just don't like being shuffled from station to station in the physicals. So there could be a couple of reasons why their heart rate is high, and we would probably just follow up on that in a less stressful situation. The next thing we're going to check in the physical exam is an eye chart. So ideally, we want to note whether or not this person wears glasses or not when we're checking their vision. Normal vision is 20/20. That means if you're normal, that you see from 20 feet away what another person who would be normal would see from 20 feet away. If you're farsighted, then you may say, for instance, have a reading of 25/20, and that means that you see from 25 feet away what a normal person would see from 20 feet away. Normally, farsightedness is not considered ideal because it can make it a little harder to read things up close. But for athletes like pitchers, it's actually considered to be a benefit because it can help them to be more accurate. As far as being nearsighted, that would be, say, for instance, if we were looking at a measurement of 20/25, that would be considered nearsighted. And that's not that big of a deal. Usually at a certain point, people will be more comfortable wearing glasses or contacts just to be able to focus and see better. But as far as health risks go, really we're not that concerned with somebody's vision until it reaches 20/500, which would be a negative 6.0 contact prescription, because at that loss of vision or prescription, and worse, they're at risk for retinal injury from sport. If they were to get a blow to the eye, they'd be more likely to have a retinal injury, so that's concerning. The last step in the pre-participation physicals is disqualification versus clearance for sport. As we already talked about, clearance for sport means that the individual can play normally and has no restrictions. As far as disqualification goes, we can have either absolute disqualification or temporary disqualification. So absolute disqualification would be for things like if somebody has a congenital heart problem that is likely to cause sudden death or severe illness, or maybe seizures for some sports or activities like we talked about earlier, maybe for a contact sport like rugby or football, or water polo if the seizures are not well controlled. And as previously discussed, if the person has a loss of a paired organ for some contact sports, that may also disqualify them. We would temporarily disqualify somebody pending testing for certain heart conditions. Say, for instance, there are certain kinds of heart murmurs that a physician may want somebody to get an EKG and an echocardiogram for before they are cleared to make sure that there are no other abnormalities within the heart. We would maybe want somebody to have testing done for recurrent concussions, especially if they were grouped close together, or an orthopedic injury. So say, for instance, if somebody's coming to pre-participation physicals and they just had an ACL reconstruction, 3 or 4 months ago, most likely they're going to be temporarily disqualified until they're finished with their rehabilitation process with that kind of orthopedic injury. The interesting thing as far as disqualification goes, though, is that we can say somebody's disqualified, and then most of the time, if a doctor says they're disqualified for sport, they'll just continue on their way and they won't try to pursue the matter any further. But technically, due to the Americans with Disabilities Act, we cannot legally say someone is not allowed to play sports. So, I had an athlete once who was a rugby player, and he actually lost a testicle playing rugby for our team. And we told him he was, disqualified, and there was too high of a risk as far as him damaging the other one and having to be on hormone replacement for the rest of his life. And he still continued to come out and do workouts with the team that were non-contact, and he was helping to coach his position, and he kept coming for about 6 months. And so finally, I knew he wasn't going to stop coming, and he didn't want to stop playing, and he'd already been playing for 10 years prior to this. So I actually talked to the team physician who had disqualified him, and talked to him about the fact that he still really wanted to play and it was still really important to him, and it may be worth the risk for him. And we ended up having him sign some paperwork that said that he was advised against playing, and he was advised of the risks that were specific to him, and he ended up continuing to play, and he played for a couple more years, and now he's actually coaching. So he never really stopped being involved in the sport that he loved, even though he was disqualified with an absolute quote unquote disqualification for a period of time. So moving on from pre-participation exams, another concept with administration and athletic healthcare is release of information. So most of the time with sports medicine programs, we are actually not governed by HIPAA. We're usually governed by FERPA, which is an educational records release or records act versus this Health Insurance Portability Accountability Act. However, the standards for HIPAA are more strict and stringent than FERPA, so that's what we usually follow, being that we are medical professionals and not educate, and the records aren't really educationally related, it's more medically related. So, when you go to the doctor's office, you'll sign a form that says that you understand that your records aren't meant to be given to anybody else other than you or somebody you give permission for, just give permission to have them. So that's a HIPAA form. So basically HIPAA states that it's illegal to give out medical information without an individual's consent. And on top of that, it must be protected. So if I was writing a note about something you told me that was medically relevant, and I left that note laying on a table where another person could read it, I'm not protecting your medical information, and therefore I'm actually violating HIPAA standards and I could get in trouble. So it's my job to not only make sure that I am not purposefully giving out your information, but I also need to make sure I'm not accidentally giving out your information. The athlete or participant must approve the release of any medical information, including to a parent or sibling or family member if they're over 18. Even if they're under 18, unless it's a guardian, we don't have to give any information to a sibling or aunt or uncle or anything like that, teen mom, any of those types of people. The only person that's allowed to have a minor's information is the guardian of that minor. Usually we prefer to have a written release instead of just a verbal release. So we don't want to be releasing written information if somebody calls us on the telephone to ask us for that information. A verbal release is okay if we're not releasing written documentation. So basically what that means is, if we were sitting in the athletic training room and we had two teammates sitting next to each other on the table, and I just got done evaluating Johnny's ankle, and Steve next door says, "Hey, what happened to Johnny's ankle?" I can't say what happened to Johnny's ankle to Steve because first of all, it's really not Steve's business. Second of all, I would be violating HIPAA if I did. However, if I turn to Steve and I say, "I don't know, you can ask Johnny what happened to his ankle if you want." And then Johnny looks at me and says, "I don't remember what you told me. Can you please tell him, or please explain to him what you told me?" That's a verbal release. It's okay for me then to turn around and tell Steve what happened to Johnny's ankle because Johnny gave me permission. So that's what verbal release is. Another administrative responsibility that athletic trainers would have would be injury reports and treatment logs. So team injury reports would be a documentation that would go to a coach or an administrator, maybe a doctor. But basically what it is it's a report that has an injured athlete's name, the nature of their injury, and maybe treatment provided. So it would say Joe Smith, ankle injury, came to rehab 3 times this week, or has been icing. But it's very, very general. They are important for legal reasons, just to show that a patient is being or an athlete is being treated and has been coming into the athletic training room and that we're aware that they have an injury. But because of the individuals that the information is going to, we don't want it to be detailed. It's kind of a gray area with HIPAA and sharing personal information with coaches and administrators. So we really need to be careful about how we're wording things in these particular injury reports for the team. As far as an injury report that we would be doing when somebody gets hurt, or an accident report, those things would be a little bit more detailed. So for an accident report, that could be used in a fitness setting. When I worked at UCSD, when we had participants from another site get injured, we would use an accident report because I wasn't going to be following up with that person as much. It was just a record saying that the individual was injured and what their potential injury was in case something came up legally. So we want the person's personal information, the description of the accident. So, Joe Smith twisted his ankle during a rugby match, had, immediate swelling and pain, and he was given ice to help with, he was given ice and removed from the match. So those would be, the personal info, description of the accident, description of the injury, and what was done to help the participant. Now, as an athletic trainer, if I was looking at the individual, I might say for description of injury, ankle sprain. But again, if you were a personal trainer or a coach, you wouldn't know how to do that. So you would just say what you noticed about what happened to them. These should be kept on file to follow up with the participant and for legal reasons. So it's really good customer service, I believe, working in a fitness setting. If somebody gets injured, you call them up and see how they're feeling. They're more likely to stay engaged and to continue to want to work out at your gym if you are showing that you care about them as a person and not just money or a number. As far as athletic training room goes, we also will do a treatment log oftentimes. It's kind of a backup to make sure that we are noting anybody who's coming in who maybe we don't have specific contact with for rehab purposes. So like if somebody's coming in to just get ice or just do ice and stim and they're not doing a full rehab program, then they would sign into this treatment log, and it's usually by the front door to make sure that we don't miss people signing in. Basically, athletes can sign themselves in prior to treatment. They can choose their own treatments off of checklists that we make for them, or an athletic trainer or athletic training student can do that for them. Another important concept in administrating athletic training programs is injury evaluations and progress notes. So injury evaluations and progress notes are also things that physical therapists would do in a clinic setting as well. Most physical therapists will use a SOAP format for evaluations and progress notes, which stands for subjective, objective, assessment, and plan. For our purposes in class, I think it's slightly easier to learn the HOPS format for evaluations to start. It's slightly less confusing. So we will actually do a lab on this so that you guys can learn the format a little bit better. But basically, HOPS stands for history, observation, palpation, and special tests. So for history, what that means, that's our first step when we do an evaluation always. What that means is we ask the person detailed questions. For example, if somebody has an ankle injury that just happened, it's an acute ankle injury, we will ask them, did your foot turn in or out when you twisted your ankle? Because that's helpful information to try to figure out which ligament was injured or which bony structure could have been injured. We might ask them, did you hear or feel a pop or a snap? Or we might ask them on a scale of 1 to 10, with 1 being very mild and 10 being the worst pain you can imagine, how much does it hurt? So those are the detailed questions we would ask in history to try to figure out as best we can what's going on with the individual. By the time we're done asking those questions, we should have a fairly good idea of what's wrong with the person within 1 or 2 diagnoses. If we don't, then we probably need to keep asking questions, but then we'll use the rest of the evaluation to determine which of those suspected injuries the person has. As far as observation, we're looking for any abnormalities. So does a person have swelling or discoloration or a deformity? Swelling and deformity are very different. A deformity, when you look at somebody who has a deformity, you're going to be like, oh man, that looks awful. So swelling is swelling. It's not nearly as upsetting as a deformity. Next would be palpation. So that's when we touch the individual to see if we can determine which structures are tender or might feel different than the other side. Usually we try to compare side to side because it can be difficult for both observation and palpation. We try to compare side to side because it can be difficult to know what's normal for an individual. Every individual is slightly different. As far as special muscle and neurological tests, those tests are specific to specific body parts and to specific structures that could be injured. So if we're testing for a fracture, we do what we call either a tap or a bump or a compression test. Those are all performed slightly differently, but they will all help us to determine if we have a suspicion for the person having a fracture. Another type of test we could do for an ankle would be an anterior drawer test. In this picture on the slide, we have a photo of an individual doing an anterior drawer test on the knee, actually checking for an ACL instability or damage. So that's our evaluation section. Once somebody has had an evaluation and is coming back for follow-up visits, then we would keep progress notes on their visits. So we do this for each treatment or rehab session, and we're going to chart this by subjective, objective, assessment, and plan. So subjective is what the patient tells us. So it could be, I'm feeling better today, or I'm feeling worse today. That would be subjective. Or it hurts when I walk upstairs. Objective would be what we did for the treatment, and anything else that we notice while they're going through treatment. Assessment would be, how did they tolerate the treatment? So a patient tolerated their X well, would be something we could put under the assessment section. And our plan would be, what are we doing next time? So if the patient tolerated the treatment well, next time we will increase resistance possibly. Or if they did not tolerate it well, we will try to substitute different exercises or different pain control methods to try to help them better. Basically, we will also try to track progress in strength or range of motion or lack thereof. So we call it a progress note, but on occasion people do not make progress. They actually will get worse. So we need to figure out, is our treatment causing that, or is it something they're doing outside of treatment that is causing them to worsen? Progress sheets can be helpful for tracking gains from personal training as well. And on the next slide, we actually have an example of a very simple sheet that you could use to do so. So I know that this sheet is a bit hard to read on the screen because the print is so small, but it is a very simple weight progress sheet that someone could use in the gym. So in the first column you have the name of the exercise, then you have the weight, sets, and reps all for that exercise, and then the date. So you could have leg press, weight 250 pounds, set 2, repetitions 10, possibly, under the one exercise. And then you could have however many exercises you had on your sheet. And then this would go over the course of 6 days under the dates there. So that's kind of a nice way to track progress. In the weight room, tracking progress could be pretty important because if somebody's not able to have progress either with the number of repetitions they're doing or the amount of weight they're doing, something's not right. So either the nutrition's off or maybe they're lifting too often, or they're doing too much cardio and too much lifting in addition to other activities they're doing. So, or, again, they're not eating enough, so their nutrition's not working well for them. So it's important to track these gains so that we know how the person is reacting to the overall plan that they have moving forward as far as their general health. And the last administrative responsibility we're going to talk about in this chapter is budgeting and ordering. So a person's budget for their athletic training room could be $500 if it's a very small high school, or it could be $50,000 if it was, say, for instance, University of Michigan. It really depends on the setting. So with a budget, we are going to need to order both equipment and supplies. So equipment are things that are meant to be reused over and over again. So for rehab, we may include ordering things like bands or cuff weights or dumbbells or modality machines. These are things that for the most part should last us. So we may give out bands to athletes, but we also should be able to keep some of those bands in the athletic training room. We may be ordering bands every time we order, but we shouldn't have to be ordering massive amounts of those. And we shouldn't be ordering balance boards every time we order equipment. A balance board should last a long time. For game equipment, we'll need coolers, ice chests, water bottles, AEDs, splints, first aid kits, things like that. We shouldn't be losing those things on a regular basis. Sometimes water bottles walk away, but we should do our best to try to get them back. Occasionally we'll lose splints because we send somebody to the emergency room in a splint and they cut it off and don't return it. So usually we try to remember to ask the athlete who we send to the hospital to bring the splint back. As far as ordering supplies, those supplies are expendable. Supplies, by definition, are expendable. We know those are things that we're going to have to order at least annually. So for the athletic training room, that would be things like tape, pre-wrap bandages, compression wraps, medications, padding, things like that. And as far as ACE wraps or compression wraps, we do try to get those back. Some of them are very expensive. The very long, very large ones are about $20 a piece. So if I give somebody a big ACE wrap like that, I expect it back. They know they're supposed to give it back. I don't always get them back, but I try at least. So again, the budget could be really small or really big, and it just depends on the setting and what you have to work with and how elite the athletes are and things like that. So that is budgeting for the athletic training room.